deal with here is the renin, angiotensin, aldosterone system. So we talked about two big factors affecting blood pressure, cardiac output and total peripheral resistance. The other big one is blood volume, and our cardiovascular system doesn't necessarily directly affect blood volume. There's some indirect effects with some peptides made in the heart called ANP and BNP, but we can talk about that in a sec. The direct effect of your blood volume is your kidneys, right? Your kidneys are the gatekeepers. They're filtering your plasma. The textbook number 120 milliliters a minute, or clinically greater than 90 milliliters a minute, is considered normal. So we're filtering that much plasma every minute, all day long, all night long, and we're deciding, okay, electrolyte balance, acid-base balance, how much do we keep of this, how much do we get rid of that, blood calcium, a bunch of hormones affect the kidney, but also some hormones are binding to the kidney and affecting, well, how much water do we hold on to, right? And that's based on a few different things. So the two main hormones that are going to affect the kidney, one's going to be antidiuretic hormone. It's made up here in the hypothalamus called ADH, and that gets stored in the posterior pituitary, not made in the posterior pituitary, and then released. The other name for ADH is vasopressin. So you have to know both names because you will hear the name vasopressin, like in the hospital. All right, ADH is going to cause the kidneys to hold on to water, okay? The release of ADH, a lot of it is affected by our osmolarity. So our plasma osmolarity, which depends on the lab you look at, we'll just use these values, 280 to 295 milliosmoles per liter, okay? So if we're dehydrated, we haven't taken enough water in, our osmolarity is going to go up. Milliosmoles is the measure of stuff, liters is the amount of fluid. So if you're dehydrated, let's say your plasma osmolarity goes up to 305, right? Well, then your blood is more concentrated because you're not intaking water. And what ADH is going to do, it's going to say, hey, this person's not drinking any water. This is going to go down to the kidney, and it's going to bind to the area called the collecting duct, and it's going to increase H2O reabsorption. Okay, or just say retention because we haven't talked about the kidneys yet. So increase water retention. And why? Because our osmolarity is going too up. It's going too high. So we need to dilute our blood because it's getting too concentrated and you're not intaking any water. So your body says, hey, we need to hold on to this water, and you'll retain more water. Flip side, let's say you're excessively hydrated and you're chugging 3 gallons of water. Well, it's going to be the opposite. So we can't hold on to all this water in our body and become fluid overloaded and get very sick. We need to urinate this out. So you're going to make less ADH because your blood's getting too dilute, right? So if osmolarity goes up, we make more antidiuretic hormone. It's going to bind to the kidney, cause water retention, and then what kind of urine are you going to look like if you haven't drank all day? It's going to be very, very dark yellow or even brown because you still need to get rid of those wastes like creatinine and uric acid and urea and all this stuff. But we want to get rid of it with as little bit of fluid as possible because we're not taking in any fluids, right? Now, opposite, if you're chugging tons of water, we need to get rid of the water. So decreasing osmolarity leads to decreased vasopressin release, less water retention in the kidney, and you have a large volume of dilute urine because you need to get rid of this water, okay? That's independently affecting ADH. Now, the other hormone we're going to talk about is aldosterone. And aldosterone is made from the adrenal cortex, specifically the zona glomerulosa, the outermost layer of the 3 layers of the adrenal cortex. And that's going to affect the kidney. So this is going to directly affect the kidney. It's going to bind to mostly the distal tubule of the kidney. And it's going to do a couple things. It's going to increase sodium retention. So we're going to increase sodium retention. So we increase, the proper term is sodium reabsorption. So we're going to hold on to more salt. And we do that because of the osmotic effect. It's going to increase H2O retention. And a side note too, we're going to decrease potassium retention. So what does this mean? We pee out more water and sodium. We pee out less water and sodium. We retain water and sodium, and then we're going to get rid of more potassium in the urine. So what's the effect of these hormones? Well, ADH, we're holding on to more water. Well, that's going to increase our plasma volume, or at least I should say maintain our plasma volume. Now, aldosterone won't just retain water and sodium. That's going to also increase our blood volume. And a very general rule, water will follow sodium. That's just because of an osmotic effect in the kidney, okay? So these two hormones are going to help regulate blood volume. Now, how does the blood pressure thing come in here? Okay, well, this all starts, or what's going to be affected by this is the kidneys. So the kidneys, if they feel like they're underperfused, so we'll just say they feel like we have decreased perfusion. It's a little more complicated than that. It has to do with the flow through the tubules of the kidneys and this thing called, these juxtaglomerular feedback stuff. Don't worry about that. And these cells, these special cells, will make renin. So basically, kidneys are like, oh, blood pressure is going down. Keep it right there for now. Blood pressure is going down. Let's release this enzyme called renin. Now here's all these steps of cascade events. Of course, this is physiology. Your liver is involved. Why? Your liver makes this inactive protein called angiotensinogen. Anything that ends in ogen, you'll hear plasminogen, fibrinogen, pepsinogen, and sometimes we'll call them zymogens for a big fancy word you never need to know. Ogen, that means it's inactive, and it's this protein. To activate it, we have to cleave off part of the protein, and we go from angiotensinogen, right, to angiotensin 1. How does that happen? Well, renin's an enzyme, and it's going to catalyze this reaction to basically break off part of this protein and activate angiotensinogen into angiotensin 1. That's step number 1. So kidneys are underperfused. Well, blood pressure's low. What do? Release renin. Renin converts this inactive protein from the liver, angiotensinogen, to angiotensin 1. Now, we're not done yet. We need angiotensin 2. So how does that happen? Well, now the lungs are involved. What the heck? What? Doesn't make any sense. That's how physiology works. They make an enzyme called ACE, or angiotensin converting enzyme. So angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. Okay? And you might have heard of drugs called ACE inhibitors, the pril drugs, NPRIL, lisinopril, ramipril, enalapril. There's a bunch of them, right? They inhibit this enzyme, and their job is to decrease blood pressure and potentially protect the kidneys to some degree. Anyway, this is going to convert angiotensin 1 to angiotensin 2. Angiotensin 2 is what we want. This has 3 big effects, okay? One effect, this is actually going to cause vasoconstriction. So it's going to have some carry over to the cardiovascular system. This will lead to an increase in total peripheral resistance because it will cause some vasoconstriction directly. That's one effect. So 1. Now, effects 2 and 3 have to do what we already talked about. It's going to stimulate antidiuretic hormone release. Remember, ADH release is also based on our blood osmolarity, but increasing angiotensin 2 will increase ADH or vasopressin. Okay, so remember, this is called another name for this is vasopressin. So antidiuretic hormone, the opposite of a diuretic, or we can call it vasopressin. So if we increase ADH release, well, we're going to increase water retention, and that's going to increase blood volume. It's also going to stimulate the release of aldosterone, right? This is called the renin, angiotensin, aldosterone system, right? And aldosterone is going to cause retention of water and sodium, and that's going to increase blood volume. So what's the bottom line here of all this stuff? We're increasing water and sodium retention, and this is going to increase our blood volume. So the third pillar of blood pressure, we have cardiac output, total peripheral resistance, and we have blood volume, right? So think of the opposite of increasing resistance. Resistance, we have, say, 5 liters of blood. We take our space and we make it smaller. We're increasing the pressure in our pipes. Now, we're decreasing it and decreasing our blood pressure. Now, what about blood volume? So we have the same size of pipes, and we shove more fluid in there, more water, more blood, what we're talking about. I'm getting confused now. It's plumbing or the cardiovascular system. We increase blood volume in there. We're going to put more fluid in the same amount of space. We're going to increase your pressure. So if you increase blood volume, you're going to increase blood pressure. You decrease blood volume, you decrease blood pressure if all other factors stay the same. So that's another direct relationship. That's the nice thing. Cardiac output, total peripheral resistance, blood volume, they're all direct relationships with blood pressure. You increase any of those, blood pressure goes up. You decrease any of those, blood pressure goes down. So, and then obviously we can use this whole system as drug targets for blood pressure, just like other targets in the cardiovascular system. So we can maybe touch on that in a short separate video. So increasing aldosterone, increasing antidiuretic hormone will increase your blood volume and increase blood pressure. And obviously there's this convoluted way of all these steps, but it makes sense, right? This is how physiology works. You might have a couple steps to get to angiotensin 2, which is the protein we want that's going to have those effects.